My name is Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. I'd like to discuss the MammaPrint assay and its strengths and weaknesses based on recent literature on this topic. The MammaPrint is a multi-gene assay. It was based on an analysis of 78 untreated lymph node negative primary breast cancers, 44 who had no relapse at 8 years of follow-up, and 34 that had a relapse within 5 years of follow-up. And investigators back in the early 2000s did a 5,000 gene microchip expression array analysis of these two groups of patients, high and low risk, and distilled down to a 70 gene poor prognosis signature called the MammaPrint. And this is available commercially now in the clinic for consideration by treating physicians in the management of early stage breast cancer. The gene expression profile, this 70 gene signature, has been shown in numerous studies now to select both a good prognosis group that have a low risk MammaPrint phenotype and a high risk group that have a poor signature with a more guarded prognosis. This gene expression 70 gene signature has been studied in a very large trial called the MINDAC study involving 6,693 patients. These patients on average were about 55 years old, about 80% were lymph node negative, but 20% were lymph node positive, importantly. 58% had T1 sized primary tumors, about half were grade 2 tumors, 88% were hormone receptor positive, and about 10% were HER2 positive. Over 2,700 of these patients tested by the MammaPrint were both clinically low risk and genomically low risk, whereas in about 1,800 patients, they were clinically high risk and also genomically high based on the MammaPrint signature. So for the low risk group in the MINDAC study, they were all treated with standard adjuvant endocrine therapy, whereas in the clinical high, genomic high group, they all received chemotherapy in addition to endocrine therapy. Now for patients in the middle that were clinically low risk and genomically high risk, or the converse, clinical high, genomic low, they were randomized to either chemotherapy or not, along with their endocrine therapy. So there was a randomization step for a fraction of the patients. Let's first discuss the low risk patient population. That group had a 5-year distant metastasis-free survival of 94.7%, which is very favorable, and it ruled out the null hypothesis, which was set at 92% by the trial investigators. So it beat the statistical aims of the trial with statistical confidence. So the low risk genomic group does call out a group of patients with an exceptionally good prognosis who arguably would not be expected to benefit from the addition of chemotherapy. That update has just been presented on this MINDAC trial with more mature data, with now more than 90% of patients with at least 5 years of follow-up. And the latest data show this distant metastasis-free survival statistic now to be 95.1%. So even a little bit better than the previous estimate on the primary analysis. Now, what about the patients that were randomized? If you look at the patients who had clinical high, genomic low tumors, there was really no difference in outcome of any clinically meaningful amount by adding chemo. So those patients may not derive much of a benefit from chemo, although ironically, the disease-free survival endpoint in that group did have a statistically significant benefit from chemotherapy, but the benefit was small, arguably clinically probably not very meaningful. By contrast, the clinical low-risk patients with genomic high signatures also clearly did not benefit from the use of chemotherapy on a statistical basis. Now, it's important to point out that these randomized subsets within the MINDAC study were relatively smaller in size and so lacked statistical power to robustly necessarily interrogate these critical questions regarding chemotherapy for the discordant clinical versus genomic profiles. In other studies, the MammaPrint has been shown to correlate with benefit from adjuvant chemotherapy. That was published by Dr. Nauer and colleagues in Breast Cancer Research and Treatment back in 2010. in a sizable trial that addressed that question of predictive value of MammaPrint. In that study, it was predictive for benefit of chemo. Finally, in the latest update in 2020 on the MINDAC study, it does appear that there are some younger patients who may stand to benefit from chemotherapy. And it may be on the basis of chemotherapy's ability to suppress ovarian function in certain subgroups in the MammaPrint cohorts. And so it is possible that there's an age-dependent effect due to chemotherapy-induced ovarian function suppression for at least some patients where chemotherapy may be considered. So in conclusion, the MINDAC data provides clinical evidence of a population of patients who are not in need of chemotherapy because their low clinical risk and low MammaPrint categorization give them such a favorable prognosis that they arguably are not in need of chemotherapy. There's a clinical high genomic low patient population that had a distant metastasis-free survival rate in excess of 94%, whether they were randomized to adjuvant chemotherapy or not. So that's an important consideration. And the clinical use of MammaPrint among the clinical high-risk patients is associated with a 46% reduction in chemotherapy prescription. So that's the power of these multi-gene assays, is to find these low-risk patients who simply don't need chemotherapy, and it can be safely avoided without all the toxicity and expense. In conclusion, the 70-gene MammaPrint is the only genomic assay with FDA clearance and level 1 evidence as defined by the American Society of Clinical Oncology, as well as category 1 recommendation by the NCCN based upon a consensus opinion of the panelists following review of high-level clinical evidence. MammaPrint is a consideration for patients who are newly diagnosed with invasive early-stage breast cancer, stage 1 or 2, have tumor sizes up to 5 centimeters, and either are lymph node negative or have 1 to 3 positive lymph nodes.